All right, good morning. Can everybody hear me okay? All right, I want to start by thanking Patricia and Mary Jo and the entire planning committee. It's been a fantastic group to work with, so I'm truly honored to be here with you this morning. And since our focus is health and well-being, I'm going to move around a little bit, if that's okay. So let's see if this works out. So when we think about the word system, at least when I think about the word system, I think of something like this. It looks fairly complicated. All the pieces are moving. They need to be moving correctly at the right time so that the whole thing does what it's supposed to do. As complicated as this might seem, of course, you all know the real systems, especially health systems, are a lot more complicated than that. We have multiple stakeholders, whether they are people or organizations. We have a lot of different physical spaces. We have limited resources oftentimes. They compete. Objectives, incentives, not always well aligned. There may be some asymmetry in the kind of information that we have. We may not always have all the information that we need when we make the decisions. And there's often some sort of uncertainty. We never have a crystal ball. So that makes the system a lot more complicated than the picture that we've seen before. When we think about systems engineering and systems thinking and the work-related stress, so again, there are a lot of pieces in the system that may be contributing to the stress, right? So it may be the demands, the pressures, not having a lot of control over what we do. It may be the culture in the work environment. So there may be a number of factors that contribute to why we experience stress, where and how. And of course, all of this impacts both the mental and the physical health. It has an impact on the organization in terms of turnover rates and patient outcomes and so on. But I want to emphasize here that the poor design or the poor management of the system or inefficiency or ineffectiveness in the system could contribute to a lot of these that we see in terms of stress. So when we looked at the literature as we're preparing for this workshop, we saw a lot of work in addressing the stress at the workplace that focused on the individual. Mindfulness training, support groups, skills training, and so on, which are tremendously important in addressing these issues. But if we focus on those alone, we may not always get the kinds of outcomes that we want or the improvements in the system. So when we think a little bit broadly about the system beyond the individual, there may be certain policies or programs that affect the people, how they feel and how they perform their jobs. We may have the processes or workflow that contribute. Information is key. So do you have access to the information that you need? Communication, protocols. Mary Jo earlier mentioned scheduling. This is just one aspect of how we interact or manage our system. So again, what we saw is that a lot of these current practices focus on individual level interventions, or maybe on a particular unit, but not so much across multiple units or the system. So again, the discussion was hopefully, we continue doing the individual or unit level efforts, but also think a little bit broader to see how everything might work across the system. So we'll talk about a couple of case studies which took a more of a systems approach to stress. And so this is a quote that I got from a healthcare professional, actually mentioned in one of the cases I'll discuss later. So you can really focus on the individual level, but if you throw people back into a chaotic workplace, there's only so much that can do. Okay, so our first case study comes from the Department of Family Medicine at the University of Colorado. Do we have anybody in the room from the University of Colorado? Okay, so this focused on the chaos in the exam room, which one physician described as similar to texting while driving, which we all know is not a good thing. So they were experiencing a lot of issues in their process on a day-to-day basis. So what they focused, at least one of the things that they focused, they did a lot of things, but I'm gonna, in the interest of time, only highlight a couple things from these efforts. They did a little bit of shift in the way they did their work. So they took some of the structured tasks, such as collecting data, medication reconciliation, and so on and so forth. And these structured tasks were transferred to medical assistants, of course, after some serious training and structuring of the process. So this meant hiring new staff members and changing the ratio of medical assistants to clinicians, but it gave up a lot of extra time for the clinicians to focus on the patient, which is really what they would like to do on a day-to-day basis. So they measured the results before and after and saw a significant improvement in terms of burnout rates, in terms of preventive health. Now that the physicians had more time to spend with the patient, they could actually address these issues and speak with the patients and motivate them towards pursuing some of these preventive services. Patients were happy, their wait times were reduced, and they were able to spend more time with the clinician. And then they were also able to add, despite all of that, a couple more patient visits in a day, which also improved access for patients, not just waiting time in the exam room, but also the time they have to wait before they can actually see their physician. So even though they added some resources, the program ended up being cost neutral, which is something that's always in the back of the administrations, so they always think about cost. And so this worked out well from that perspective as well. So when we think about this system, we always need to think about the people in the system. Who are the stakeholders and how are they affected when we do a change? So in this case, I just listed some of the stakeholders. There obviously could be others. But overall, from the perspective of these primary stakeholders in this case, it was a positive change in terms of their experiences in the system. So our second example comes from Stanford School of Medicine. Anybody from Stanford in the room? Okay, wonderful. So please chime in if you would like to add more. So they estimated that physician burnout costs a lot of money at Stanford. And this was due to overworking, long shift hours, pressure about performing, publishing, bringing in grants, and so on. So they implemented a system called the Time Bank, a pilot program, which really tried to ease some of the pressure on the physicians. And here's how it worked. So they are involved in a lot of activities that are very useful in terms of supporting each other, but they are not rewarded they were not rewarded in the previous system. So, for example, mentoring, serving on different committees, stepping in if a colleague has to be away last minute. So all of these different kinds of things they did, but there wasn't a way of acknowledging or rewarding these kinds of activities. So basically, you had to do them pretty much on your own time. So under this new time bank system, when you engage in some of these activities, which are really beneficial from the perspective of the system, you actually get credits. And you can use these credits either for professional reasons, such as getting some academic support, or you could actually use it for personal reasons, such as meal delivery and dry cleaning and so on. Sounds very nice. So after they implemented this pilot program, they saw a lot of positive change when they surveyed the physicians. They felt more support. Female faculty members in particular ended up using this program a little bit more because historically they were actually the ones, when you look at the data, who were more engaged in some of their activities, and now they are actually getting some credit for being engaged in these activities. For volunteering to cover shifts, stepping in and helping a colleague, that doubled, which is really good from a morale perspective. And faculty also now ended up having a bit more time to discuss science and other things with their colleagues. So overall, they were happier in terms of their work-life balance. So in terms of the impact on other parts of the system, funding is valued highly. It's important. So they also saw an increased success rate and also increased amount in the funding that's brought in by the faculty. So this is, again, something that will make the administrators happy. In terms of the fellows, they were happier too, and they did not have any turnover after the implementation of this pilot program. So they were very happy about that. So this particular one focused primarily on physicians. So you might ask, what about the others in the system? The nurses and all the other healthcare providers. Any impact on them? So the studies that I looked at did not discuss the other stakeholders, but that's something that we could definitely discuss. If you implement a program for a particular group in the system, how do the others feel if they are not, they don't have access to these kinds of rewards? So again, the stakeholders in this particular pilot, physicians, the organization itself, and of course the patients and several others. Okay, so our third example comes from Karelian Memorial Clinic. So this is a relatively large health system, both in terms of their physical presence and also the number of staff and patients that they see. And they've been experiencing very high levels of burnout, as you'll see on the right side of the slide, pretty much across the board. And so one thing about this system is that they serve populations where the patients might not have insurance, they might not be using preventive services, they may have certain lifestyle choices that actually do not align with their physical condition. So it was a very stressful environment for the healthcare professionals serving in this particular system, given the majority of the patient population that they were working with, and particularly in the emergency department. Many patients would show up in the emergency department where they did not necessarily need emergency care, or maybe they would not need emergency care if certain things have been done ahead of time in a different environment, more along the lines of preventive care. So they built a network of local nonprofit agencies to care for patients who really could actually be seen and treated outside of the ER. And again, I'm giving you only bits and pieces of what they've done. They have the comprehensive approach, engaging in some other activities too. But essentially, again, the idea was, let's take out some of these workload, which really doesn't belong to this part of the system, and it could be handled elsewhere more efficiently, effectively, benefiting the patient as well as helping us focus on what we really need to focus. And again, the impact on the physicians was quite positive in that particular example too. So this last example, I actually had the opportunity to work on this particular one, was from a pediatric intensive care unit in a children's hospital. So they expanded, they moved into a new place, which sounds like something very positive. They had more beds and more physicians and the space was good, but they actually saw a lot of metrics go the other way because they were still utilizing the processes that they used in the previous space, which didn't really exactly translate with this expansion. So they had increases in rounding duration, which meant patients were actually being discharged later than they could have been. This meant that maybe we have people waiting in the emergency department, ready to be admitted, but we are not turning over here, so they have to wait longer, and so on and so forth. So there were a lot of issues. And then the patient families were also very frustrated. So the way the system worked, the physicians would move from one room to another. There was a lot of chaotic movement in the space. The nurses didn't know exactly where the physician was. The families didn't know when the physician would come and actually speak to them and give them an update. So they had to hire an extra resource just to manage this chaotic situation. So to track down the physician and actually update the patients about, okay, it's probably going to be another 15 minutes before they come and see you. So the approach here was, okay, let's take a step back, systems engineering approach. Let's first understand where the issues are. So we looked at the symptoms, some of them I listed above, and we quantified them so that if we made a change, we could actually go back and measure and see again the impact of that change on the system. So we mapped the process so we could understand all this spaghetti diagram of movements in the system. and focused on standardizing some of these steps, both to reduce the times and also to reduce the variation. We focused on the essential components, which of these things that we do are really essential for patient care versus which of these we could probably reduce. So we looked at a lot of metrics and results before and after. These were a lot of stakeholder involvement in this. Nurses, residents, patient families, physicians, all of them were involved in providing feedback about the current situation and the kinds of improvements they would like to see if there was a change. And the metrics from the perspective of all these different stakeholders looked quite positive after the implementation. So I'm going to mention just one thing here, which I always find interesting in terms of our way of thinking about the processes. So traditionally, when they were doing the rounds, they would start with the radiology rounds. They would actually go to a different floor to view the images and then come back and then visit the patient rooms. And we asked, so why are you following this process? Because historically, that's where the images were available. But today, as you all know, you don't need to go to a specific location to view the images. So they basically eliminated those rounds, and they decided to view these images inside the patient's room. So that saved them a little bit of time and also have this discussion while they had access to the images. And the other piece was education. Education is very important. This is the teaching hospital. And there was a lot of variability in how different physicians, attendings were doing education to the residents and fellows. Some of them would take very long time in a particular room discussing that particular patient, maybe skipping the next one very quickly. And that really created a lot of variability in terms of the rounding time. So after this was implemented, the decision was made to reduce the time spent on education inside the room, but they added another session at the end of the rounding process so that they could actually all come together in one place and discuss these different cases, which gave an opportunity to the learners to also hear about some of the cases that they were not present during the rounds. And overall, the learners were actually quite happy with the changes that were made. So I'm going to conclude by jumping to my system slide, which is slide number 27. Whoever is, if you could just help me jump there to 27 real quick. OK. So just wrapping it up, I think there are lots of opportunities in terms of bringing together design thinking, systems thinking in the medical world, in the healthcare system. Always need to keep in mind that focusing on one group or one unit and really optimizing that one perfectly doesn't mean that we are optimizing and improving the overall system. So I think there are lots of ideas that we could merge from design thinking and systems thinking to take a more holistic approach so that we can focus on different metrics and how a change that we make might impact all of these different metrics and stakeholders. So one thing that we do in systems engineering is, again, we focus a lot on data and measuring. And sometimes before we actually make a change, we may have a way of testing it, for example, via simulation. So actually, we can see the effects and do a lot of what-if analysis. If we do this, what happens? And see some of the impact before the actual implementation. So that goes along with the design thinking, the prototype approach. So this is sort of like having a prototype, but testing it before you actually implement it. So thank you very much for your attention, and happy to take any questions or hear your thoughts and comments. Thank you.
Well, thank you very much, Pinar. I'll open the floor to the forum for both questions as well as comments, stories, examples you might want to share. Mariana. Then we'll come back.
Mariana Klatt from Ohio State. And Pinar, my question is on the Stanford example, we're doing the exact same thing, the concierge services, but they are doing it with physicians. And my fear is that the nurses and the other, so what, is there a recommendation there? I would love to be able to take back a recommendation. It needs to be.
So our colleague from Stanford, I don't know if you have any comments on this one. You may have more inside knowledge. Okay. So that's a good question. That's also what I mentioned. I'm not sure what the impact was. That was not something that was reported. But that's a very good point and a very important point.
So Pinar, one thing that struck me in that example, when you looked at how much Stanford was losing in this department, and it was, I don't know, 7 million or something, and the cost of this program was 250,000, in the implementation. If you look at other professions, Mariana, like you mentioned, the cost of replacing one nurse in a system, depending on if they're a critical care nurse or, working on a floor, approaches $100,000. And so many, I think that's part of the case we need to make in advancing these strategies. There's kind of a human case and there can be a clinical case, but actually there's a business case. Because I think if we can reduce turnover and improve retention, as well as improve engagement and satisfaction, we can actually be saving dollars to the organization. So while there's a cost to these programs, ultimately we can be really saving dollars. Malcolm.
Thank you. I finally got the microphone. Malcolm Cox, University of Pennsylvania. So the examples that both Tim and Pinar have given to us are wonderful examples of success stories. But it's intriguing to me that we seem to keep reinventing the same thing. For example, design thinking is a new term for from the bottom up. And I'm not sure that simply relabeling things leads to real change. It gives snappy new titles. So I would just warn us all that many places have been doing these things from the bottom up as opposed to the top down. And while it's useful to have new models and so on, I'm not sure it really leads to real change. And my question for Pinar is, so if you really want to test how successful these things are, you need to look at scalability. And you can look at scaling up of the microsystems, the mesosystems, or the macrosystems. And I wonder to what extent you have evidence outside of these wonderful isolated examples of scalability within the different systems that you're talking about.
I think that's a very good point. That's one reason why I wanted to discuss the fourth example, that a system or a process that worked very well when they were smaller did not work that well once they got bigger. So I think that's why we need to rethink sometimes the way we do things in the presence of, it's different now, the space is different, in the presence that technology is different. We may have access to new information, new technology that we did not have before. I think either Mary Jo or Tim mentioned that this is not a final thing. You do it and you are done. It's really a process. So that's how I think about it, both the design thinking and the systems thinking. It's a process. We need to continuously go back, revisit, we do something, and then it brings us to a certain point. But there's always something that we could potentially do better, especially considering that things change. And scalability is one of them. You maybe do it really well, but then once you go up to the next level, you may have to rethink about some of the steps. So that is also part of systems thinking, and I understand it's also part of design thinking.
Yeah, I mean, it seems to me what the scalability issue gets at is it removes or normalizes for the passion of the innovator. You can get change simply from the passion of the people who are implementing the change, and that's an important component of change, obviously. But moving it outside that with different contexts is much more difficult, and that's why I think the scalability within the different systems that you're talking about, micro, meso, or macro, would be a really wonderful set of examples, because healthcare is so complex.
Thank you very much.
Thank you.
Back at table 6, I think there was a question or comment. Was there somebody back?
Yes, Patricia Hinton-Walker, Uniformed Services University. I wondered if you were familiar with, I think his name is Peter Hawkins, who talks about and writes books on systemic team coaching, which is, he really talks about that frequently when we get into this systems engineering, we're looking for who is creating the problem. And we end up thinking, well, if we can just fix those people, then we'll have the problem fixed, but it doesn't work that way. And he talks about that really the focus is in between the different players. And are they all seeing the same quote unquote customers? So for example, he uses with the medical assistants that they really see the physician as their customer, not necessarily the population. And so he recommends creating shadow teams. So you might have a group that would look at what you did here to bring things together, but then create either a shadow team of other players or a shadow team of other groups of disciplines or from the community. And then they say what they think the solution is, and then you have to put it back to the primary team and say, okay, you have to resolve this so that all of the different teams their issues are being addressed. And so his book is, I think it's called Leadership Team Coaching. He is a dominant person out of England. His name is Peter Hawkins. You might want to explore his work.
Thank you so much. That's a great comment. So, with systems thinking, it's usually not so much looking at individuals or even groups of people. It's more really looking at the system and how the different pieces interact. That's where the quantification comes into picture. So going back to say a hospital or a clinic environment or a hospital environment, let's say, you may be experiencing long wait times in the ER, and you may look for the cause of this in the ER, but the cause may be somewhere entirely different. It may be because the way we schedule our cleaning crew in the rooms is completely off with the demand, and which means we are not cleaning up our rooms in a timely manner, which means the room is ready, empty, but we cannot bring a new patient. So it's not really pointing fingers. It's more really, if something is not working well, we need to take a step back and think, what is it that we as a system are not providing, either in terms of processes or resources, so that people can actually do their job the way they want to. So I guess it's again, complement some of these other approaches, which may be more people or individual focused, but we kind of take a step back and really look more on how the different pieces fit together. But I'll definitely check it out. Thank you for the recommendation.
Leading the team.
Thank you, Patricia. Caswell has a question.
Pinar Keskinocak, University of Illinois, Chicago. Excellent presentation, but both presentations brought to my mind the following question. In the context, we're still looking at subsystems within a much larger system. And these subsystems are interwoven, they're overlaid, they have complex interactions among these subsystems. In this process and in the evaluation, how do we determine that improving one system does not pressure another system so that the stress is really just transferred in the larger system? You're improving on one side, on the other side you create stress that did not exist yesterday.
Yeah.
How do we deal with that?
That's an excellent point. I mean, in manufacturing, we call it the shifting bottleneck. So you fix this portion because that seems like the bottleneck, and then you just shifted it to another place. So I think some of it is inevitable when we make a change, that these pressure points in the system might shift. But the goal is really not to make any one of them excessively bad, and hopefully overall all of it is getting a little bit better. But I completely agree with your comment that we have to be very careful about the unintended consequences in other parts.
Recognize that it's occurring and know where it's
Exactly.
So one thing that I've noticed, Caswell, is that there's more and more organizations that are saying, we can't address this from the perspective of one discipline or one small problem. This is really about creating cultures of well-being. And when you sort of frame it in a bigger way around cultures of well-being and really engage a larger group of stakeholders and really look at a number of systems and processes that need to be changed, I think you have less likelihood of just sort of shifting. But I share your concern, and I share your concern about, I'm intrigued by the Stanford time in the bank model, but I do think sort of differentially, sort of treating one group so different than another group that might have similar issues could have, adverse consequences. So I know, Zora, you had a comment, then we'll go over to this table.
Actually, thank you. My comment is, I think, a nice complement to what you're saying, that as I'm reflecting, we're thinking a lot about, well, one, if you think about it, what makes a resilient individual or organization, there's the ability to rebound and recover, but then there's also the strength of that organization on the flip side, the health and well-being of that organization to be stronger. And much of what we've been talking about are problem-oriented. How do I respond to this and recover and resolve that issue? And there's the other part of this is, how do I build a healthy, resilient, well organization that may not be crying for help today? And so I'm just thinking about it from the other side. And Pinar, actually, I was wondering, when you have a problem, you know where to go, you know you can theoretically go to that problem and try to understand it, but that's the respond component. If I'm a leader and I want to build a healthy organization, where in the system how should I approach that problem from a systems perspective, not having a problem, but actually wanting a more resilient, healthy, well-being, organization? Does that make sense?
Absolutely. Yeah, I could not be, more in agreement with you. When we think about the healthcare system overall, we call it healthcare, but I call it sick care. It's a sick care system, not a healthcare system. Usually we address the issue after somebody gets sick. And the amount of emphasis that we put on, or the resources that we make available for prevention is not as much. So this is just from a patient's perspective, the way the current payment systems and incentives are aligned. The healthcare systems get paid when somebody gets sick and show up, and they do, offer services or treatment to the patient. So how do we turn this around and say, really, we don't want anybody to get sick, and we just kind of focus more of our energy and resources on that. So the same applies to an organization too. How do we do that? That's really not very straightforward. But I guess one way to approach would be really to think about, ideally, what is it that you want to see? Really, again, thinking about our metrics in terms of the health and well-being and the resilience of the organization, and keeping an eye on them, and thinking about the ways of how can we even make this better, even though we may be in a good state right now, everything seems to be working fine. How do we make sure that to make it even better, so that we can respond when there's a change, or when there's a change in our scale, and so on, we still continue, in a positive direction. But that's a very good point.
So it strikes me, Pinar, one thing that we can do is ask different questions. So if the questions that we're asking is, why are people leaving, and why are they turning over, and why are they stressed and burned out, that might lead us down one path. But if we ask people what brings joy in work, and what engages them, and what sort of keeps them and makes sort of their life, vibrant, I think that can lead us down another path. And I think that's partly why, even in framing the workshop today, instead of having it a workshop only on sort of stress and burnout, we framed it as, how do you, create resilient organizations and really focus on resilience and well-being. So we have time for probably 2 more comments before we take a break. Is there anybody that... Okay, Michelle, and then in the back. Thank you.
I'm Kathy.
Yeah, Kathy, and then in the back. I was looking at the
So
wrong
in
thing.
capitalizing on that, I was thinking, one of my experiences, I was a hospital supervisor on 9/11 when the plane hit the Pentagon. And I was at the trauma center where the patients were going to come, so we implemented our disaster plan. And we were really good at clearing all these beds. We got all these kudos, that was fantastic, you clear all these beds. I said, that's nothing, be here on a Saturday night on your 5th code and you're trying to make a bed and no physician wants to respond to your call. So it kind of echoes that capitalizing on your success. We were very good at implementing our disaster protocol, but we don't do it on a regular basis. It was when we had this huge disaster and everybody came together. So I was wondering, in your systems approach, that concept of capitalizing on your successes and what you're really good at, and then disseminating that across your system in a different way.
Yes.
Okay.
Okay.
Hi, this is Charlie Alexander. I am the director of the NAM Action Collaborative on Clinician Wellbeing and Resilience. And I just wanted to put in a quick plug for the Action Collaborative because we do take a systems approach to ensuring clinician well-being. So we have representation from medicine, pharmacy, nursing, and dentistry to address some of the questions and concerns that came up here. We want to make sure that a solution for physicians, for example, doesn't exacerbate the issue for nurses. And so we have professional societies, healthcare centers, health IT vendors, payers, as well as residents and trainees as part of this collaborative process to ensure that all heads are at the table as we develop solutions, also so that we have bought-in stakeholders when it's time to implement. So I just wanted to highlight that we have a conceptual model that discusses all the factors affecting clinician well-being and resilience, as well as a knowledge hub where people can go to learn more about how to take action. So I just wanted to put a plug for that. Thank you.
Well, thank you, Charlie. And I actually refer many people to that website. And I can just say that it's an amazing repository of resources. And I think it will really become, it has become kind of the go-to place for not only accessing literature, but also accessing information about tools and practices and exemplars. So it's really a great website. Any final question or comment? Yes, John.
I actually just want to make a comment that follows up on yours, Mary Jo, which is as we go through the day and tomorrow, I would love it if whenever people could, if they would speak to this issue of changing your language from focusing on stress and burnout to focusing on joy, well-being, resilience, because I think it's a very big issue in our process. And I know that we struggled with it some in the committee, right, to get to where we were. And when people are locked into a disease model, it's hard to even actually say well-being for a lot of people. They just don't believe it's a possible outcome. Joy is not a possible outcome. So I think if we can bring that thinking into what we're doing, it would be very nice to reflect it out in our responses.
Well, thank you very much for that comment, John. So we will bring to a closure this first session. We have a break until 11:15. So ask that you be back so that we can start right on time. Thank you very much.